Welcome to the Jim Wood Speaker Series. We have had excellent speakers throughout last year, and we started this this speaker series last year with the idea of bringing leaders in different industry to come and share their experience. It may be about certain aspect of what they do with a certain company, or we have had people come and talk about the economic downturn and what caused that. Several bankers came by. Today we have another very timely speaker because we have been hearing about healthcare debate on TV. You cannot avoid that. Today we are fortunate to have Ms. Sally Sidwell. She is the Chief Operating Officer for Kaiser, Georgia. And I was just reading through her bio. And I was thinking, what was one word? I mean, she has been a leader and executive for the last 25 or so years. She's an all-rounder. She's done it all. And she has been with several companies, several big companies, Cigna, United Healthcare, ADP. She has worked on the strategic planning side. She has worked on the insurance side. She has worked on the benefits side. She's now working, obviously, as a CEO of Kaiser Permanente, Georgia. Extremely active in several organizations. I was just looking at Partner Circle Against Domestic Violence. She's chaired the ADP Executive Women's Leadership Board. We have a women's leadership program here, so we need to talk about that. Served on the board of Atlanta Technology Cooperative. She has been recognized by the Southern Christian Leadership Conference for her activity with them and in trying to set up a similar program in Charleston, etc., etc. She and her husband Joe live in Atlanta. She holds a Bachelor's of Science degree in Education from Westchester University in Pennsylvania and has completed an executive leadership program from Harvard Business School. Please help me welcome Ms. Sally Sidwell.
Good morning, everyone. I'm Sally Sidwell, Chief Operating Officer of Kaiser Foundation Health Plan. Can you all hear me in the back? That's good. My kids can usually hear me too, through the house. I'm excited to be here today. You have a beautiful campus. Last night when I was preparing to come here, my daughter said to me, "Mom, have you been down to Clayton State lately?" And I said, "No, I haven't." And she said, "Wait till you see that campus." So she's very envious of the campus that you have here and what you have going on. She attends Georgia State. But so anyway, I don't know if that's good or bad. No. Anyway, I'm pleased to have a chance to speak with you, to talk about something that I think everyone in this country is talking about today. You can't help but open a newspaper, turn on a TV, or listen to a radio and not hear about healthcare reform. So we'll talk a little bit about that. I don't have all the answers. I have opinions. Actually, we at Kaiser have opinions and thoughts on it. And those opinions or thoughts are what I'm going to share with you today. First, I'd like to give you a little bit of background about Kaiser Permanente. Let me ask you, by a show of hands, how many folks are familiar with Kaiser Permanente? Oh, wow, that's great, awesome, great. Well, I don't know if you know this, but our history dates back to 1930. In the middle of the Mojave Desert in California, Sidney Garfield, who was a young physician, was working with individuals who were building the Los Angeles Aqueduct. And he knew at that time that individuals may be reluctant to pay money for health care when they needed it and so forth. So he set up really what was the first prepaid health plan in the United States. For a mere 10 cents a day, individuals could pay in and they could use his services. So think about it, a dime a day, 70 cents a week, or maybe about $2.80 a month, you would receive health care. That's a great deal. Anyway, the arrangement enabled Dr. Garfield to build healthcare facilities, hire doctors and nurses, and he truly believed in maintaining the workers' health. He believed in prevention and making sure that they had everything they needed. Of course, he was going to treat them when they were ill or they had injuries, but the primary focus was on prevention. This innovative concept captured the imagination of industrialist Henry J. Kaiser, who saw it as a way of keeping his workers healthy. So when World War II broke out in San Francisco, Kaiser was building ships that were being used for World War II. And in an effort to help his workers, he set up a delivery program leveraging Dr. Garfield to treat those individuals working within the shipyards. When the war ended, it was such a huge success. Kaiser and Garfield said, hey, let's not just continue to offer it to these individuals that worked in the shipyards, let's offer it to others. So at that time, 10,000 individuals joined Kaiser Permanente and the organization began. Today, Kaiser is one of the largest not-for-profit healthcare organizations in the country. We have 8.7 million members. We have 156,000 employees and nearly 14,000 physicians. We began operating in Georgia 25 years ago. Actually, in 2010, we're going to celebrate our 25th anniversary here in Georgia. And you'll hear a lot about it over the next couple months and through 2010. There'll be a lot of advertising for our 25th anniversary. Today, we have 260,000 members that we serve here in Georgia, and we have about 2,500 employees. Our mission is to provide high-quality, affordable health care to our members and the communities we serve. And that's really important. It's core to our values. So if you're a Kaiser member, we love you. If you're not a Kaiser member, we'd love to have you. But just because you're not a Kaiser member doesn't mean that we won't provide you services. If you go out to any one of our 15 medical office buildings, we have Healthy Living, a series of programs that we offer to the members who use us as well as non-members. So you can go there and learn about diabetes, healthy cooking classes, healthy living classes, Tai Chi, Pilates, yoga, and so forth. And that's part of us giving back to our community. Today, we continue the legacy through our focus on health promotion and prevention. And for those of us who've chosen healthcare or the health insurance career, it seems that we've been talking about healthcare reform for decades. It seems that it really is a time for healthcare reform. And I want to give you a few facts. Probably many of you are aware of them, but if you're not, here they are. Close to 50 million Americans have no health insurance. 200 million get their insurance through their employer or private health insurance market. 80 million get their coverage through government programs, mainly Medicare, Medicaid, and federal employee benefit programs. Costs are spiraling out of control. Healthcare is projected to consume 20% of the GDP in the United States by 2020. And finally, and closer to home, in Georgia, 20% of the state's residents under 65 do not have health insurance. That's 1 in every 5 of our citizens. So, without putting people on the spot, I'm going to ask you, how many of you here do not have health coverage? Raise your hand. And it's interesting, actually, I expected it would be a lot more than that. Because the highest population of individuals that don't have coverage are between 18 and 24. So I applaud all of you others for having coverage, but for those of you who don't, we need to have a solution for you. And at Kaiser Permanente, we believe deeply in that, and we're incredibly supportive of President Obama and what he's trying to do and accomplish. The last and interesting fact is that this is not just a social issue, it's an economic issue. The cost of caring for the uninsured is shifting to those of us who have coverage. So those of you who are sitting here along with myself who have coverage, just because you have coverage doesn't mean that you're not paying for the uninsured. You are paying for the uninsured. And a lot of that money, according to a very recent Families USA study, cost shifting is adding over $1,000 per year to each insured family insurance premium, most of which are paid by our employers. So why is it so expensive? Well, the reason is that many of the uninsured don't get primary or preventative care as it's needed. So they're sick, their condition gets worse, and especially for chronic illnesses like diabetes, congestive heart failure, coronary artery disease, asthma, and depression. These 5 diseases account for 75% of the national health care spending. So there's individuals out there who have these diseases and sicknesses, yet they don't seek help until they're desperately ill. When the uninsured do not get care, they often end up going to the emergency room, which is not really designated to provide primary care. And so therefore, the care is less effective and it costs more. So we agree there's an urgent need for healthcare reform, but the question is, how do we go about addressing this problem? At one end of the spectrum is a proposed solution that people call a single payer solution, or universal health care, where the government coordinates and pays for health care for all. Think of it as Medicare for everyone. Doctors, hospitals, or other Medicare providers would reimburse directly to the government set rates. And while this approach might limit the administrative cost and payment rates, it would unravel our employee-based system that currently provides the coverage to a vast majority of Americans. Furthermore, it would stifle or probably kill the competitive market as we know it today and stop innovation in the private sector. Some suggest this approach would be the precursor to rationing healthcare in the United States. The other end of the spectrum of solution is to base healthcare reform solely on competition in the private marketplace and also place a huge emphasis on individual responsibility. Proponents of this approach claim that consumer education and consumer-driven models, along with competitive marketplace, will contain costs. Most would agree that this approach has done little to the overall healthcare cost or to improve access. So if you think about it, that's really what a lot of us are leveraging today. And still we have individuals who are uninsured and we don't have coverage for all. At Kaiser Permanente, we believe that the answer is somewhere in between. A mixed model approach that subsidizes coverage for those who cannot afford it and expands existing public programs to fully cover people whose programs are intended to cover those individuals and revitalize market systems building on employer-based model that has worked for decades. At Kaiser, we believe that the mixed model has the greatest potential, but alone it's not enough. We believe that to truly fix the healthcare system, we need to address three key components, and those key components are universal coverage. There should be coverage for every citizen of the United States. And there should be no restrictions based on pre-existing conditions. So we believe that individuals should have care, it should not be limited, and that what you receive should not be limited based on conditions or things that you may be diagnosed with or because of family would be predisposed to. The way care is delivered and prevention and community health. First, we believe we need to get everyone insured. Universal coverage will require two things. All health plans must guarantee coverage to Americans, including those with the prior conditions. Second, in order to make coverage affordable for all, everyone has to participate. Americans must be required to obtain health care coverage. A mandate should be accompanied by subsidies for lower income individuals to help make coverage affordable. And I think of it like this. This is like having, if you drive a car, having coverage for driving that car. Everyone should have automotive coverage. You get pulled over, the police check, there's databases now to ensure that you're carrying that coverage and so forth. And that's not only for your protection, but for the protection of others. If we can do that and coordinate that, think in the automotive industry, why can't we do and coordinate that in the healthcare industry? In short, we believe that if we're going to make healthcare affordable for everyone, we must spread the cost of the care across the entire population. Also important is ensuring everyone it's not the entire answer. We need to change the way we organize, deliver, and pay for healthcare. This is where we believe Kaiser Permanente is a model for healthcare reform because the way our physicians coordinate care and the experience for our members. At Kaiser Permanente, we have great doctors, medical staff, and hospitals, but our nation's healthcare system is no system at all if it's uncoordinated and fragmented. Within Kaiser, I'm so excited because we have what we call the electronic medical record, or EMR, and we believe that it provides our physicians with a significant advantage because if you show up at our Southwood facility and a doctor sees you and runs labs, but then you end up going up to Alpharetta or Brookwood and you see they refer you to another physician, that physician doesn't have to run a series of labs or tests because it's already been run at Southwood and it's in the electronic medical record, and the doctor at Brookwood or anywhere, any of our 15 medical office buildings can pull it up and can view those results, so that we're not ordering unnecessary tests, and we know what has happened throughout your history of being a Kaiser member. And we believe that that same process and that same infrastructure should apply to healthcare across not only Georgia, but across the United States. Today in the United States, we rely on medical records and their paper, which are often incomplete, inconsistent, and many times you can't even read those. I remember when I was little and going away to college, having to go back to my pediatrician. And I still have the records, actually. We got all the records and we brought them to school to prove that we had shots and so forth. And not long ago, I was looking through them, and I can't read them. The writing, it's beautiful, but I can't read it. And when you think about that and you're dealing with someone's life, you should be able to read that information, and you should understand what it's saying as you're providing care and treatment to an individual. So we do need electronic medical record system for everyone, and the right electronic patient information than what we have today. At Kaiser, we've made a huge investment. Actually, we've invested about $2 billion in our electronic medical infrastructure that we leverage across our members. I was saying earlier to a couple folks, here in Georgia, we run 2.7 million labs on an annual basis. If you look at our 15 medical office buildings, every day we have couriers going around picking up lab samples, and we take it to a centralized lab out at DeKalb Tech, and we run those. Within 24 to 48 hours, that information is uploaded into our system, and if you're a Kaiser Permanente member, that information is available online to you. And really, that is the way healthcare should be delivered. It shouldn't be that you go to a physician office, that the lab specimens are placed in a white box, and that a courier comes and picks them up and places them in the U.S. Postal Service that goes to a lab out of state that processes that information, that then sends it back to that doctor's office via paper form, and sometime 2 to 3 or 4 weeks later, you get either a card in the mail or you get a phone call. That information truly should be online, because time is of the essence when you're dealing with individuals and you're dealing with their lives. But we do use KP Health Connect. Our doctors and care teams coordinate care using that at every point of the spectrum of service that a physician might need it in the office, the lab, the pharmacies, the hospitals, on the phones, even online. You know, when you call in to our call centers, we get 166,000 calls a month in our appointment and advice call center, and we get another 60,000 calls a month just here in Georgia into our member services call center. All that information, if you're calling in as a Kaiser member, our reps can go back and see what's in the system. And if you're ordering something or you need something other than an appointment, which a clerical administrative person will help you with, if you need to speak to an advice nurse, those individuals will transfer you to advice nurses in many different specialties, whether it's ambulatory care, pediatrics, OBGYN, or all the specialties. And those nurses who are triaging you on the phone have all your medical records and information right there at their fingertip. So they can help you if you call in the evenings or on the weekends, and they can say, hey, either come into our medical office first thing in the morning, or based on your history, based on what you're telling me, you need to go to the emergency room. So we're pretty excited about how we leverage that information. And it also, as I mentioned, we provide those tools online to our members through kp.org. As a member, you can also send a secure email to your doctor or schedule appointments. You can see your labs, you can order prescription refills online, and you can also have, if you're on maintenance medications, you can order them and have them mailed to your home from the system. This kind of healthcare system should be available to all Americans. In addition to addressing fragmentation, we need to change the financial incentives so that doctors are rewarded for the quality for keeping their patients healthy. Payment should be based on quality outcomes, not on the number of services provided. So many of you are business majors, and you understand when you're running a business, what feeds the business is top-line revenue growth. That's what feeds the beast. So when you're running a healthcare system and you aren't incentivizing your doctors by paying them salaries and paying them out on outcomes, you're incentivizing them in a different way. You're incentivizing them to feed the beast. So if you come in, it behooves them to run a lot of tests. It behooves them to set you up for procedures that you may not need. If you think of a child who has inner ear infections and so forth, many times the solution is let's just put tubes in the child's ear. Versus our docs will say, maybe we should treat the child with a series of antibiotics and follow up on a more regular basis to treat the underlying issue. And then, and only then, if the child needs tubes in their ears, we place the tubes in the child's ears. So there's a lot of things that we believe at Kaiser where doctors in the community are incentivized differently than the Permanente physicians. In today's system, there's little financial incentive for keeping people well. In general, providers are paid for each service, and then that drives up utilization. The last piece of the puzzle is community health reform. We must focus on disease prevention and community health. There needs to be a profound cultural shift. All Americans need to realize that protecting their health is just as important as maintaining their cars. And that means after the warranty period. So when this is happening, coverage will be far more affordable. It will also lower the cost of Medicare and Medicaid. So you think back earlier, and I talked about the 5 diseases that make up 75% of the spending. And if you think about diabetes alone, let me ask you this. How many of you work out on a regular basis? Raise your hand. And how many don't work out at all? Let's be honest. So some work out in between. Okay, let me ask you this. How many work out 5 days or more a week? Okay. And,
4.5.
huh?
4.5.
4.5. We're gonna, I bet you when I tell you this next fact, I'm going to have you up at 5. You know, diabetes. You think about diabetes. Someone who's diabetic, if you would work out 30 minutes a day, 5 days a week, you could have a 50% chance of reducing diabetes. 30 minutes a day, 5 days a week. Clearly, there are health costs and benefits to lifestyle and healthy eating and active living. So true healthcare reform really begins with all of us. So if you're sitting watching TV or listening to talk radio as you drive into school or work, or you're reading magazine articles or the newspaper, yeah, it is about our government, and it is about us and how we work collectively, but it begins with each and every one of you. And if you're not working out, you need to look at that. If you smoke, you need to think about smoking cessation. If you're not eating right, you need to think about eating right. If you're not drinking water and hydrating your body, you need to think about hydrating your body, because healthcare reform begins with each one of you. In closing, to reform healthcare in America, we can best achieve that reform with a combination of public and private approaches that include universal coverage, that reforms the healthcare delivery system, and that focuses on prevention and community health. It's an exciting time in our country, and it's a wonderful time to work at Kaiser Permanente. I so believe in the Kaiser brand. It's an excellent organization to work for, and we believe that we don't have all the answers at Kaiser, but we do believe we have a lot of them, and we're working closely with the Obama administration. On May the 11th, actually, George Halverson, who's our CEO, was in Washington along with the heads of a lot of industry, meeting with President Obama. But we believe higher quality, more efficient, accessible, and healthcare will significantly reduce or change and make it more affordable for all Americans. So I thank you for your time today. I'm happy to answer questions and so forth, but it's a pleasure being here with you. And it's a pleasure being here with you because you are the leaders of tomorrow. You're the leaders in healthcare, and you're the leaders in business. And what's going on is really important, and you're going to help shape and change that and deliver it for years to come. So thank you for your time. Question? Yeah.
You mentioned about pre-existing condition,
Yeah.
coverage for that. Also, you gave the analogy of policemen checking insurance because it is the law.
Mm-hmm.
But somehow, we need to make sure that I have the insurance before I got into an accident or before
Right.
the cop stopped me.
Right.
So isn't a pre-existing condition kind of like that, where I don't wait for my condition to appear before I run to the, just because I'll be admitted anytime I get in?
Yeah, so, well, a pre-existing condition, a lot of healthcare organizations today, if you apply for an individual coverage, they can limit or they can deny you coverage. And what we're saying is we don't believe that pre-existing conditions should be taken into consideration. We believe if you apply for coverage or you want coverage, that you should be able to buy it, just like you could buy auto insurance, right?
That's a great thing to do.
Mm-hmm.
My question, however, is if we did that, or if you all did, everybody did that, wouldn't people wait to get into trouble before they come and buy the insurance, because you would accept them anyway?
Well, I think
Just like if I came to auto insurance and say I had an accident last week, now fix it,
Mm-hmm.
because I want insurance tomorrow.
well, the plan would be to ask people to get insurance, to hold them accountable for that. And the reason for having the health care insurance would be so that you're not just coming in when you have an accident or you find something, that you're coming in all along. So from the time of birth, an ideal system would be from the time of birth you're covered, and that we're treating you throughout your lifetime, so that as a child you're getting the appropriate inoculations, that you're getting the appropriate preventative care, and that you're being taken care of, and it's more of in a proactive type arrangement versus reactive. You know, people who only seek care when they're sick is like a train wreck, right? It's much better, you know, if you're diagnosed, heaven forbid, with a cancer, and it's found precancerous cells or skin, you say, you know what, you've been out in the sun too much and you look like you're predisposed because your family, you need to do this, this, and this. That's far better than someone showing up with melanoma that's stage 3 or 4. Or when they've discovered a mass or a mole or something, and they said, well, it started off really, really small. Well, it's best if it's really, really small, you come in, you have it taken care of, than when it grows a lot bigger. Yes?
You said that you wanted everyone to be able to have health care and everyone should pay into the system, but will there be some type of competitive rate because everyone doesn't make the same type of income? So, or will
Yeah.
it be like a sliding scale,
Yeah.
a standard sliding scale for
Yeah.
different incomes?
Yeah, I don't know how that'll work. I mean, obviously individuals who can't afford it, we need to subsidize it. And I would guess that there would need to be some type of scale. I know, you know, at Kaiser we don't have all the answers. It seems like that would make sense based on perhaps income and so forth, but I don't know. I think that still needs to be worked out. But just because you can't afford it doesn't mean you shouldn't have it. And I think we got to solve for that. I think that's a tricky thing. Yes.
You may not have the answer to this yet as well, but what about on some policies now you can have, it covers more than others where you just might have major medical or that
Yeah.
sort of thing. Will this cover everything, or will it be kind of like auto insurance where you can pick your coverage, what type of coverage you want?
Yeah. Well, I think for healthcare with the pre-existing conditions and so forth, it would be more comprehensive than picking and choosing different things. You know, a lot of people say, well, I don't want coverage for pregnancy, but I want it for this or that, and you can buy policies based on that. But the fact is, if you're, you know, childbearing years, you should have coverage for childbirth. And I think we got to figure that out and figure out, you know, I don't think limiting things is the right thing. If you're talking about treating people and you're treating them holistically and preventatively, and if they're diagnosed with something, then we should treat them for what they have. And I think it gets kind of dangerous, you know, when you start slicing and dicing it. Because that's kind of what we have today, and that doesn't really work. Yes?
If you got a sudden influx of 200,000 patients,
Mm-hmm.
how quickly could Kaiser provide care for those people, and how many jobs would it provide for the School of Business?
Oh, we would love 200,000 members. So we have, so it would be a challenge. It would be a challenge to get folks hired and so forth. Today, we have 15 medical office buildings in the metro Atlanta area. We're adding 2 more by the end of this year, one in East Cobb and one in Decatur. Over the next 3 years, we plan to, in 2010, we're going to add another 6 to 8 medical office buildings. And at the end of 3 years, our plans are to improve our footprint and have about 30 offices in the metro Atlanta area. So then the next thing, if you think about Kaiser here today in Georgia, we aren't fully set up like California. So we have 8.7 million members on an annual basis, of which 6 million are in California. California is the true Kaiser model because we have our own hospitals that we own and operate. Here today, we have a strategic relationship with 3 hospitals, Piedmont, Northside, and CHOA, Children's Healthcare of Atlanta. And we only have 260,000 members, so as much as we'd like to build our own hospital, the battle that we always have is where would you put it? If you put it downtown, then the people on the north and south side say, oh, it's too far of a drive. If you go one way versus the other, people are slighted. So eventually, we hope to grow our membership. We think somewhere around 400, 500,000 is the right number for when you build a hospital. And we're trying to ramp and build up to that. We have a relationship here with Clayton State where we come and we like your nurses and folks from your school. They've been great, and we have a lot of great employees that have come from here and other schools, quite frankly, in the Atlanta area. My direct reports, I've charged each of them with going out and building a strategic relationship with each of the universities that provide not only nursing, but different services and so forth. And we're doing that now in an effort to build those pipelines so that as we grow, we'll have a good view into candidates and we can fill those positions. If we were to get 200,000 members overnight, it would be a significant challenge. It would be a significant challenge. But it's a challenge we wouldn't mind. Yes, ma'am.
I hear what you're saying about the vision and goal that you like to see with the healthcare. Well, what is Kaiser's stance on pre-existing at this moment? Because I know from personal experience that they don't accept the pre-existing.
Yeah, that's right. Today, we do underwrite our individual, when we sign individuals and so forth. The goal is to get away from that. And we want to get away from that. But if we were, so Kaiser is only one vendor within the marketplace, right? If we open up and we say we'll take everyone without pre-existing conditions, what happens is it's called adverse selection. So we then take on the sick population. And it places a tremendous burden on us compared to Aetna, Cigna, United, and the Blues. What we're saying is let's level the playing field and let's get rid of the pre-existing conditions for all and spread the disease burden so that you don't have the adverse selection and you don't have the influx. We want to treat people, but you can't do it at the expense of tanking the organization as other organizations thrive and grow and don't believe in doing that. So we do underwrite business today, you're absolutely right, and we do limit it based on pre-existing conditions, but that's not that isn't really what we want to do, but if we open the floodgates, we get impacted with adverse selection. Yes, sir.
I was listening to your model about how providers should be reimbursed, incentivized actually. But healthcare is a business, and if they're only paid a salary and have no incentive, so they charge less, that will stop the revenue coming in. So it runs into a problem where they're not being able to provide the same amount of resources with less income coming into the company. So
How do you run your business?
like, how do you run your business if you're planning to charge, if you want to charge less? It's like you're gonna have to cut back if you try to charge less.
So at Kaiser, our physicians are paid by salary, and they're incentivized too by outcomes and preventative care. And so many of them will say that they went to medical school because they care about individuals and they wanted to treat individuals. And what many of them will say, and maybe the next time we'll bring a physician with us, is that they didn't go to school to worry about the dollars and the cents and what's charged for what. They really went to medical school because they have a huge desire to care and to serve other people. So our physicians are paid via salary and they're incentivized by that. They earn a very, very nice living. They're very, very happy. And I will tell you, although we're a not-for-profit organization, we do make a margin. And as a not-for-profit organization, what we do with that margin is we pump it back into two things. We pump it back into the business by building additional medical office buildings, and we pump it back into our community by giving grants and so forth. So we are not-for-profit, but we're able to, with very competitive rates, compensate our physicians, get better outcomes, make money, put it back into the community, and put it back into our organization to grow. So if we could do it, I think others could do it. Yes, sir.
Okay. I work for a medical facility now, and I know a lot of our new providers that we're hiring, they went to the school for the same reason, but they find themselves closing down because of overhead issues, the malpractice insurance. That's why a lot of providers leave, stop doing their own practice, which that was their dream. They had to have to force to be working with other bigger companies that can't afford to take on that malpractice insurance, all the overhead, because most of them clueless about as far as the billing, the money. They're good at being providers, but as far as keeping the clinic running, billing correctly so they can keep their practice running, that's where they have that disconnect. So I'm guessing that in the new model, it will have to be that if the price is getting low, the volume of patients have to be higher. Is that going to be the way to compensate? If I just have 4 patients, I have to charge a little higher just to have my reimbursement, but I can lower the price if I see everybody in this room. You know what I'm saying?
Well, I'm not really following that, but I would tell you, we serve 260,000 members today. We cover malpractice. We have, next year I believe 100% of our physicians will be board certified. We have some of the best physicians in the country. They went to medical school to practice medicine. They'll be the first to tell you. We don't want to worry about keeping the light and the heat and the air on and keeping the staff in place and paying the malpractice and running the operations. They look at me and they look at my peers and they say, that's your job. And that is our job. And you know what? I didn't go to school to treat people. And if there was an emergency, I'd be the last person you'd want on the scene. I'm good outside waiting for the fire truck, but inside where the stuff's going on, not my power alley. So I think what you have to do is you need to look at individuals and you need to look at their strengths and their abilities and what I call their power alleys. I'm a very good business person and I'm a good operator. I understand what my doctors need and how they need to be supported, and I listen to them. And what I do for them and what the CFO does for them and other folks is allows them to practice medicine. And so that they don't have to worry about the business component, and they don't have to worry about hiring or terminating people, and they don't have to worry about all that other stuff. We do it for them. And we do it for them as a team, and we get great outcomes. And so I would say at Kaiser here in Georgia, as well as on a national basis, our model seems to be working. We have very good business people partnered together with great, great clinicians. And we've achieved some really awesome outcomes, and we're able to reinvest in the business, and we're able to reinvest in the communities that we serve. So, yes, ma'am.
With the predicted shortage in nursing that's coming up, we found that many of the current nurses who have are choosing not to retire. Are they staying on longer?
Interesting. We have some nurses that are retiring, some that are staying on. I don't, you know, I'm going to say something, this is probably going to cause a whole controversy. I'm not so sure there's a shortage. I haven't, we go out, I don't know, maybe it's us as an organization and we attract people, but we're able to get people. And since being at Kaiser, there hasn't been an RN, LPN, MA, lab tech, rad tech, pharmacy position that we've had open that we haven't been able to fill. Now, if we get 200,000 members, I might be back down here crying. But I don't know. I haven't felt it. And I don't, many, like I said, there's a lot of our nurses that are staying with us, but I think it's because that's their desire, their personal situation for whatever, and then there's others that, you know, they retire. So we haven't really, no. Yes?
Sally, you used a lot of analogies with auto insurance, and they were good analogies, but yet in auto insurance we're incentivized to be better drivers by getting lower premiums, and yet in healthcare coverage we don't do that.
Right.
And you have identified that healthcare's got to start with us, and you ask how many of us exercise. Why doesn't the healthcare coverage industry incentivize the consumers to be healthy themselves?
Well,
We do things in this country when we're motivated. The best way we're motivated is through money.
yeah. Well, I think that's true. That's true. I think we think they should be incentivized. You know, people who work out and people who have certain blood levels and who maintain their weight or BMI at a certain level, then perhaps they should be incentivized. I think, again, we're not automobiles, and I use those analogies, but I do think there are some components and pieces of that that are pretty valuable. I mean, if you're a safe driver and you don't have a lot of wrecks, that's a good thing. But you got to be careful because you can't penalize people who have conditions or who are sick and it's out of their control. But I think that there should be incentives, and we have this debate at our office all the time about, you know, incentivizing individuals for working out and for healthy living and maintaining their cholesterol levels and taking beta blockers and so forth after they've had a heart attack and so forth. I mean, there's a lot of different things, and we should incentivize people. And today with our electronic medical record, we can capture and track all that, but that's a little bit big brotherish, and people don't like it either. So I think you got to strike the balance. But we do believe that there are opportunities for people to do things differently and be held accountable. And I think a monetary incentive is a great way because money motivates a lot of people.
And just a quick follow-up question that also doesn't make a lot of sense to me is you have a lot of healthcare insurers who have obviously drug formularies, and a lot of those drug formularies are exclusive of things like Chantix, smoking, cessation, etc. So essentially you're saying to your covered life pool, well, keep smoking because we're not going to pay for the medication that's going to prevent you from doing this, which is going to give you a greater escalating cost down the road to you as an insurer. So that rationale escapes me. Why would so many of these plans eliminate things that are leading towards better health?
And I think today it's done out of cost to control costs and so forth. I'm not saying, I agree. And long term, it's not the right thing to do. But I think that a lot of folks have and take knee-jerk reactions, limit this, do that, and it solves a near-term issue, but not a long-term issue. And again, I think this is a very complicated matter. And I don't think there is one answer. There's a lot of work and a lot of wood that needs to be chopped to figure this out.
One more question?
Yes?
You say that you want to cover for everyone with a pre-existing condition, but if you and your competitors have to do that, would that not raise the price of healthcare throughout America?
No, because I think it would spread the pool of those individuals who aren't receiving health care today, and it would get them in. And there might be a spike initially, but I think if those, and what we feel is if those individuals had treatment on an ongoing basis and were receiving care on a regular basis, that it would level out. And that eventually, if you were taking everyone in and you were treating them or doing whatever preventative measures were needed or required, that your long-term costs would level. So there may be an initial spike, but long-term, what we believe is that that would level out.
But then do you think people would be happy in that short-term spike to pay for people with a pre-existing condition?
We're paying for it today.
But I'm saying, would that not be just the same thing that you're saying with the insured people paying for the uninsured people? The same thing as this, with people without a pre-existing condition paying for people with a pre-existing condition?
Yeah, I think initially you're going to have a cost impact, but I think, again, it goes back to if someone doesn't have health care today, or someone doesn't go and seek treatment when they have a pain and they're an ongoing running pain until they're doubled over, and then they show up in the ER and it's stage 4 cancer, that is very, very costly. And versus if you catch it earlier on because people have coverage. I mean, you're going to pay, you have to treat the issue, but I think where you engage and how you engage that individual, and earlier on, and I mean, a lot of you are healthcare professionals, there's a lot of things if you detect or you catch it early on, it can be prevented and you can have a long, fulfilling life without hundreds of thousands or millions of dollars in medical bills because you're catching it at the very end and you're trying to extend someone's life 12 months.
I agree with you that in the long term it will be less, but how would you be able to deal with that short-term spike? Because people without a pre-existing condition that aren't insured, the people with a pre-existing insured, there's going to be a huge influx of them coming to the company. And you just said that if you had to open it just for your company and your competitors didn't, you would have this influx and your cost would just be too high.
Right, because of adverse selection. So if I open the doors, or Kaiser opens the door, every person with a condition who doesn't have coverage today would come to us. So in other words, as much as we'd like to say we won't limit on pre-existing conditions, we would set up adverse selection, which we would be treating the sick, all the sick, and the others, i.e., would not be taking on that. And what we're saying is open it up equally so that everyone shares and spread the sick population evenly across everyone. Does that make sense?
Yeah, kind of. Just that almost seems like that would happen in an ideal world.
Yeah, but so if you think, let's think about this. If you have Aetna, Aetna, Cigna, United, the Blues, Humana, Kaiser, there's 6. If one opens up and you get all the population going to them and these other 5 don't, that means they continue on, they take only the healthy, and life is good, and they make money on them, and they do nothing, and you then tank this one business over here. Versus if all 6 open up, and they have to take on the sick population and treat them themselves, all of them, you're not adversely impacting one organization.
Okay, and then would that not create more people? Sorry, I know.
They're going to give you the hook.
The absolute last. Would that not create more people with a pre-existing condition to create an influx in all one of your competitors as well as yourselves?
Well, I think when you spread it across 6 versus 1, it's better, and there'll be an initial spike, but then it should level because those people aren't getting treatment today, and many of them, if they get treatment, they're engaged in their care and they're receiving whatever they need, it'll level out.
Well, please give her a... Thank you so much. Something very small for you.
Thank you.
But thank you for the questions. I hate to do this because we run out of time, but it's always great when we have a speaker and we run out of time. So this doesn't mean you should stop asking questions. This doesn't mean you should stop coming to these sessions. So please do continue to come. I want to really thank Dr. Sidwell. Obviously, he makes it all happen, makes it look so simple, but a lot of work goes behind it. We have got the student ambassadors who do a wonderful job. Of course, our camera is always appreciated, our camera person. So thank you to all of you. See you for the next time, but once again, thank you so
very
much for
Thank
taking
you.
the
It was a
time.
pleasure. Thank you.